Do we have participants?
Yes, we have participants sitting here. They're
Okay.
just coming back from lunch, so they are a little slow.
Hello, Kutolo. How are you? Can you hear
Fine.
me?
Hi. Chai.
We can hear
Ciao.
you
I
perfectly
don't see you. I can't see you.
You can't see me? They
No.
can't. He can't see me. Huh? He's going to focus on me. Don't worry. I think you'll be seeing me soon.
Now I see
Hello,
Vanessa. Ciao,
How are
Vanessa.
you?
But we don't see you.
You still don't see me. Okay. Just bear with me for 1 more minute.
Yes. Probably there are some problem in your camera.
They're just, I think, connecting the camera.
Okay.
Hello.
Ciao, Vanessa.
Hello, Vanessa. Can you hear us?
Hello.
Ciao, Vanessa.
Can you hear me?
Yes.
I can't hear you.
Can you hear?
I'll take off just 1 moment. Can you hear me?
Yes. Yeah, we can.
Wonderful. Now I can hear you, not with the microphone. I will do without the microphone. Hi, Maurizio. Hi, Sarah.
Hi, Vanessa. How are you?
Fine. Thank you so much.
Thank you so much for taking part in this this workshop, virtual workshop, which is, one of a kind in our part of the world. So I'm hoping that one day both of you can come over and do it in person so that we can learn from you.
With pleasure, Sarah.
Sure.
We still don't see you, but maybe you have no camera or something wrong.
Yes, they're just connecting. I think trying to fix the
Yeah,
problem.
now is a switch off. Okay. You
yeah.
can switch on? No.
No.
No way.
Now my name is Saira. Now it says I'm Saira.
I don't know why your name is Saira.
Somebody change me.
हो सकता है नो नो जो लोग कहीं जाने नहीं सकते ना साइरा से वो उनको मेरे से थ्रू करा रहे हैं 1 सेकंड पैनलिस्ट में
Just give us
Magicians.
a few minutes.
I see maybe 14 participants, 14.
We can hear you as well as see you, but just the IT people are trying to figure out the video or picture.
No problem, Bilal. With pleasure.
I think it's because 2 people have signed in with the same name. You also have your name, Saira.
Would you like me to go out? But I signed in with Vanessa, but somebody changed me to Saira. Would you like me to go out and come back in?
Yes.
I go out and I come back in, okay?
Okay, thank you.
See you soon, bye-bye.
Okay, bye-bye.
No way.
Let us check for a minute.
Microphone.
Otherwise, you should send me another link.
Yes.
What you can do is send me another link, because the link you sent to me was for 1 panelist. So if you send me another link, I can, or if you send to Saira another link, the issue is that per presenter, there can only be 1 link. So the link that you sent to me is a personal link. This is why Saira can show herself.
Oh, just let us see what we can do.
No worries. Okay.
This
Dr.
is a
Saira is
private
mailing
link.
you another link, and you can join with that link.
Maybe best to send to Saira another link, because if you send
No,
me
to
a
all
link
of
and it
us.
doesn't work,
I think if you send a link for us and participants, one link, it's better. And we link all together to a new link. Because I see 13 participants, but I don't see the icons of participants.
Just give us a few minutes. The IT people are figuring
no
out.
worries, no worries.
Professor Smith, can you please check your email? Dr. Saira has sent you a link. Please leave with this link and join with the other link.
With pleasure. With pleasure. I will look for another link. One moment, please.
It's in your email.
I got also. I must use this one?
No, Dr. Cotolo, you can keep using this one.
Okay,
so
because
now
I received the same mail. Okay.
Just, Dr. Smith, you need to leave this link and use
With
the new
pleasure.
link.
I close here and I come back.
Okay. Yeah, you leave this link and then join with the other.
Yes,
link.
I leave this and I go.
Yes.
Wonderful. See you soon. Bye-bye.
Oh, bye-bye.
Bye.
Okay, now we can see you, and you've joined with your name.
Boys?
Yes. Good afternoon, Professor Coutelot. Tudo bene?
Perfect, perfect, perfect. Now I recognize you.
Everyone in the audience can see you. If you two want to say a few words, everyone can see you and would be able to hear you. If you want to say welcome or anything to the participants.
Tell me when to start.
You can just welcome them all. They are seeing you.
Ah, they are seeing and are hearing me. So,
yes.
Welcome to all of you. I am Professor Cutolo Maurizio from Genoa, Italy, and with me, the other speaker, Professor Vanessa Smith from Ghent, Belgium. We are from several years involved in capillaroscopy, and this is a fascinating field of research, clinical research, that is just at the beginning, I say, because we have a bright future, and you will see from our words how it's expanding the need to evaluate the microcirculation, the status of vessels, in particular capillaries, because the majority of the disease, autoimmune disease, infectious disease, and many other metabolic and other causes have a signal, a dysfunction, a damage of the capillaries. And with an easy microscope, like is a video capillaroscope, you can detect and calculate the severity. Okay, I don't want now to say too much. I would like to tell you that the program is constituted by 4 presentations. My first presentation, you will see, is how to evaluate the microcirculation from morphological and functional point of view in autoimmune connective tissue diseases, particularly rheumatic disease. The Professor Smith then will follow with standardization for the evaluation of the capillaroscopy. It's important to standardize and to use all the same system, the same nomenclature. And then me again, showing how important that the very news and update on capillaroscopy in pregnancy, in normal pregnancy, in pathological pregnancy, and what is materializing, unfortunately related to the COVID, what is published, and the new and exciting result in acute, in survivors of COVID, in children and adults. So brand new news. And then again, a break. You will bring to us your cup of tea. We will drink with pleasure. And then Vanessa she will present the algorithm. The algorithm is important to distinguish easily the standardized, the capillaroscopic scleroderma pattern from the non-scleroderma pattern. So if you tell me that I can start to share but you have disabled my screen share, please make possible for me to share the screening, because when I click, I see that the host disabled participant and I cannot open my sharing. So if you make possible for me to share, I'm ready.
Hello, Dr. Cucciolo. Can you see me?
Yes.
Hello.
Some way.
Hi.
Okay. Yeah.
Okay, thank you. Thank you. Hi. Now, we have some connection that you are able to see me and I'm able to see you, and everyone in the audience can see you. So I think we should start before the other things get settled. Is it okay?
Yes.
Wonderful.
If you let me possible to enable the sharing of the screen, I will share my screen.
Okay. Allow Dr. Cucciolo to share his screen. So let me start.
Thank you very much.
Bismillah ar-Rahman ar-Rahim. I welcome you all to the nail fold capillaroscopy virtual workshop in this Silver Jubilee Pakistan Society for Rheumatology conference. Firstly, I would like to start by inviting the chairs. Our chairs for this session are Professor Dr. Nigat Mir Ahmed. She is the head of rheumatology at National Hospital and Institute of Rheumatic Diseases. Our second chair for the session is Professor Muhammad Ahmed Saeed. He is the professor and head of rheumatology at Central Park Medical College. Now let me introduce you to our first speaker. Our first speaker for the day is Professor Maurizio Cucciolo. He is the professor of rheumatology and internal medicine, director of laboratories and experimental rheumatology and academic division of clinical rheumatology. He is director of postgraduate school of rheumatology, University of Genova, Italy, and he is also the advisor of Euler School of Rheumatology, ESOR education. And he would be delivering his first talk on how to evaluate the microcirculation in connective tissue diseases. Over to Professor Cucciolo. Are you able to
Thank you very much, Bilal, for this introduction. Welcome to all of you. I hope you will enjoy after 2 hours of intensive news. I would like to start with my first presentation that is related on how to evaluate the microcirculation. And this is, I hope you are, you are able to see now.
Yes, we can see your screen.
Yes, we can.
Okay, I put in the full screen. It's okay?
Yes, now it's full screen.
Perfect.
All right, and I start. How to evaluate the microcirculation. This is a very important point, and the Euler study group on capillaroscopy and microcirculation, and who is interested of you to participate is invited, because Vanessa Smith, she is a chair, and we are open to over 45 countries at the present. So I can say an important aspect. We can consider the microcirculation from both sides. The morphological point of view, so what we can see with imaging, static images, and the functional analysis. So what is going on the blood flow, in the structure, in live motif, or even combining the morphology with the functional analysis. And we have the tool for evaluating both system of analysis. So it's clear that we start such kind of analysis when you have a clinical sign of peripheral blood insufficiency, damage, like Raynaud phenomenon. And this occur frequently in beginning of systemic sclerosis, even in primary Raynaud phenomenon. We will see how important to distinguish the primary from secondary associated with autoimmune rheumatic diseases. This is a very important point, to have the tools to evaluate the morphology and the function of the failure of the microcirculation in the distal part of the circulation. That means it ends primary in the ends at the level of nail fold. The tools to evaluate the nail fold microvasculature are several. Some are very cheap, some are more expensive, and depends what you want, what you like. You want to do a very fast screen, you need a cheap. But if you need to collect the picture, analyze the picture, score the picture, use the picture for the follow-up, use the picture for publication, use the picture for teaching, and so on, you need a system a bit more sophisticated with the software. And we suggest, because you buy once and for all the life, you use this. It's a very easy way, is a micro camera, usually, not use anymore the microscope. And this is the very easy dermatoscope or USB, very cheap, but it's a just direct evaluation. With a capillaroscope, you have the possibility to memorize, to use, to compare, to count, to work after the examination, or maybe after 1 month when you need, when you have time. The quality is at the top, of course, with using professional lenses with 200 micrometers, the dilation, the magnification, and you can see, we will discuss how can see the different aspects. It's clear that if you look at the skin, you see the whole lesion. If you look much better at the nail fold, you can see the structure. For example, this is a giant from the skin, giant from the nail fold, angiogenesis from the skin, angiogenesis from the nail fold. This is what we need, because we can count and we can have a wonderful quantization to have this kind of evaluation. So the timeline for the introduction of capillaroscopy, we can say that start capillaroscopy around the 70s. And it started already with some hallmark, important aspect, like the giant means scleroderma pattern, and other few that then conditioned the evolution of the much sophisticated way to analyze the microcirculation. And starting from the microscope, soon after 20 years, started the analysis in the 90s with the video capillaroscope, with the storing and all of the things I told you. And became so important that in 2013, almost 10 years ago, the capillaroscopy analysis was included in the American College of Rheumatology, European College of Rheumatology classification guideline for systemic sclerosis. So now capillaroscopy for rheumatologists is the daily tool, device that they must have, especially if they discuss about primary Raynaud, secondary Raynaud, and of course, autoimmune rheumatic disease, in particular in the case of systemic sclerosis, where today the damage, the morphological pattern, and the evolution, the progression of the damage is now validated and well known. It's clear because the microvasculopathy that started with the damage of the endothelium that may be due to, for example, chemicals, or maybe due to the cold, maybe to the trauma, maybe due to combination of different causes, start the production of local activation or local inflammatory reaction with microvascular damage. This is the first step in the majority of diseases, not only in autoimmune rheumatic disease and systemic sclerosis, but we know even in diabetes, for example, the damage of microcirculation is an important point, and the clinical consequence in diabetes follow the damage of the vessels and the endothelium. So the damage of the endothelium that we can see very easily and in direct manner without any risk for the operator, the patient, just because it's just a microscope and you look in the microscope without any radiation or other technical change or indirect imaging. It's let you see what is going on. And this is a normal condition. Many of you already saw. This is a nail fall skin. And you can see in the nail fall skin, the sequence of the capillaries or in a very ordinated and sequential array. Eventually, this condition may be associated with the primary renal phenomenon, but primary renal phenomenon means only vasoconstriction in presence of stimuli, but not morphological changes. What happened when something starts that damage, as I mentioned it to you, the beginning of the disease? The beginning means damage of the endothelium. Damage of the endothelium means dilation of the capillaries, dilation, loss of red blood cells, and then with the progression, loss of fluid. And you can see here, for example, a completely normal capillary, as you expect in normal condition, but you see some asymmetrical abnormal dilation. You see here, you see here, you see here. This is what we consider today, and it's already published, the very early nail fold capillaroscopic appearance of a possible progressive lesion. And you can search on literature this paper, and more than 1.7 of this dilation, 1 millimeter, means that the patient is moving versus the possibility of the very early signal that is characterized, as I mentioned, by a dilation between 20, up to 20 is normal, over 50 is a giant, between usually 30 micrometers. So an abnormal enlargement that several times people that use a capillaroscope observe, they don't know which value to give, represent a beginning for the real morphological and functional damage. And already we observe negative predictive values of the absence of dilation over 30 in patient with primary renal phenomenon. So the dilation over 30 were considered already signal of damage, of course, of normal capillaries. But the predictive value, so the negative predictive value, the not progression to the classical giant, this is over 20, but under 50, this is over 50, many times over 50, maybe 150. This, the predictive value was, can I say, with an important sensibility, was important because already you know that you are under a threshold, you cannot develop a secondary. But as I mentioned, the second step was to evaluate the positive predictive values. And maybe Professor Smith will mention it to you a few words about this. The continuous damage, the pathophysiology of the disease that involve all the cells of immune response, including B cells, molecules like adhesion molecule and other cytokines, particularly growth factors, TGF-beta, endothelin, platelet-derived growth factor, and vascular endothelial growth factor, produce more and more abnormality, but specific abnormality, like the giant capillary. If you observe just one giant capillary in your ninefold capillaroscopy, this means that this renal phenomenon is already associated with the progression of disease. Take care of this, the giant capillary. And the giant capillary is very easy to recognize, is associated with increased permeability, maybe with swollen fingers, microvascular hemorrhages, and you can recognize easily this signal, the dilaton, the collapse, the hemorrhages, and this is the early pattern. Even only one giant compared to the normal capillary, the giant one, with symmetrical dilation, all branches is the signal. But the signal moved, the damage moved because more cells and more cells participate with the production of autoantibodies, even functional antibodies that mimic the mediators of the disease, like the angiotensin converting enzyme and vasoconstriction and so on. And the damage increase, more giant, more giant, more giant, more microhemorrhages and more capillaries die. And so you start from the active to have a loss of capillary, edema, fibrosis, and you see the giant together with some regeneration starting. The angiogenesis, you see the hemorrhages, you see the loss of capillary. And very few are the normal capillary at this step when you have the active. And this is the progression. And unfortunately, the progression activated all the machinery for the fibrosis that include the fibroblasts, macrophages, and two resident fibroblasts, but even adipocyte, and even the transformation endothelial cells in myofibroblasts. At the end of the story, started the real fibrosis in the body. We know that it wants to stop as soon as possible this step. And new approach with combination therapy are going today to achieve such kind of results. So this is the morphology. And the morphology that with the late pattern that Vanessa will explain, we will not won't see anymore in the future. Vanessa will, Professor Smith will mention it in the first act. She will present very well how to distinguish what I just told you from the pathophysiological point of view. But there are other systems, very recent, to evaluate the morphology that include a much more sophisticated way, are not yet for the clinical daily analysis, but may be useful for advanced research if validated for the photoacoustic, optical, or optoacoustical imaging. And this is a system that lets you see the capillaries with a more sophisticated raster scanning combination of non-invasive, of course, but three-dimensional analysis that let you see the capillaries in the three-dimensional with a different color related to the intensity. This is the normal capillaroscopy. This is the OAI analysis, and still matter presented 2 years ago of intensive research. And we will see in the future, you see capillaries with increased volume, angiogenesis here. You see angiogenesis, you see in healthy condition regular capillaries, and you see some dropout of capillaries from the microarray. So in some way, it's a more picturesque, but also three-dimensional view of what we can see with capillaroscopy, even with the dermatoscopy. Tell me to tell you some difference between the different tools for the microvascular analysis, the morphological. The microscope, the nightfall video, the dermoscopy, the SO, and acoustic imaging that I mentioned. I can say that the count is almost possible with all the tools, as well the capillary shape, if you see giant or dilation. But looking at the calculation of the width of the capillary is not possible with dermoscopy and not with RSMOM, possible with the OAI. But what is important for us is the direct visualization of capillaries that is not direct, but indirect, because you need some sophisticated electronic evaluation in 3D. The microscope is not portable. The video capillaroscope is possible portable, clearly. The other two apparatus at present are not portable. So if you want to do an analysis of your patient, the bed of the patient, or in a dynamic way, bringing with you is not possible. Important is also today the possibility of automatic or semi-automatic capillary count. And we have some system, especially for nasal capillaroscopy, that do that and count for you. The image storage, as I mentioned, is possible every time you are connected with a PC, and you are not possible to connect, you cannot connect, or it's more difficult to connect with the dermatoscope, but with all this system, you store image. You can have a dedicated software, again, not for the dermoscope, that USB or USB, they are very cheap, but what is cheap sometimes is also not too much efficient. The time, the need for the execution is important. Short for the majority of the system. With the system with sophisticated software, it's a little longer. And the practical use for the daily, that is related also the possibility to be portable. It's possible with stereomicroscopy, but not portable. But it's possible to use during the day in your ambulatory, the nasal capillaroscopy and the dermatoscopy. So we have, at the end of the story, different system and the possibilities. The cost is high with the stereomicroscope, moderate, but you buy once and then use for all your time, and much more cheaper for the dermoscopy USB, and very high at present, very high for the most sophisticated system that are the system I mentioned before to you. Then we developed, many other systems have been developed for the absolute count and the number of capillaries and density, because at the end of all the study, we validated publishing during the last 10 years, the number of capillaries is still the most important parameter that you should consider. And the follow-up of the patient is based on the absolute number of capillaries. In the sense that with the progression of any kind of disease, you observe a loss of capillaries. And when you have a stable disease because of the therapy, for example, you have no change over 3, 6, 12 months, the number of capillaries. But when the disease progresses and increase the damage of the microcirculation, endothelial destruction, and so on, like in diabetes, I mentioned, there is a loss of capillaries. So the number of capillaries is the most important. And the sophisticated system were able, and now are able, because they're part of software, to count automatically the capillaries with a mixing of color, density, position on the space. And so at the end, you have the possibilities that you can see to detect the single giant and to distinguish the giant for easy dilation or other cross-linkings or other differences. And so at the end, you will see the different aspects, and you can count this with the automatic system. Vanessa Smith will explain to you much more about the pattern, but here just to see how the number of capillary decrease with the progression of the disease, and you move from 7 to 10 to 13 up down to 2, 3 capillaries in advanced disease through different and progressive deletion and destruction of capillaries. And so with such system that was validated versus manual exploration, the results were very, very important. The ICC was very, very interesting, counting the absolute number of capillaries. So the validation about the count of capillary number was found very, very significant. Another important point is the possibility to detect all the changes in other autoimmune rheumatic disease, the scleroderma-like pattern, that is the combination of all the different changes, dilation, giants, hemorrhages, angiogenesis in one shot in a very active disease, for example, in dermatomyositis, or in mixed connective tissue disease. It's important to know that exists the scleroderma-like or the comb-like pattern that you observe. Anytime you have microthrombi in disease characterized by microthrombi was observed in antiphospholipid syndrome, but now is observed also in lupus with combined antiphospholipid syndrome, and even in COVID, severe COVID with microthrombi. So this is a pattern that is becoming more and more present. How to evaluate at this point the microcirculation, the functional aspect? Of course, the infrared tomography is the most, I can say, cheap, easy, and picturesque, because you see the color and you understand what means blue and what means red. Red is good circulation, blue, lower circulation. So it's clear that in Raynaud, the circulation is lower in the finger and in the doors, in the palm, where you have arteria and arterioles and not capillaries like in the finger, the circulation is always good, better. But in the smaller fingers, the circulation is blue because it's reducing. You can have also a score in some way based on the temperature. You can evaluate thermography, and you see that blue means lower temperature, red higher temperature in your hands, on the hand of the patient. Of course, laser speckle contrast analogy is a much more sophisticated system. Is not direct, is indirect. A laser beam evaluates the speckle, the movement of the single red blood cells in 1 millimeter, and evaluate the blood flow. You see a good blood flow, very intensive movement of red blood cells, and you see here in the dorsum, on the palm, on the dorsum, and you see here in healthy, again, you can see in the dorsum, it's a little less possible to see the microvessel that is possible to see with the laser speckle. Laser speckle observe the microvessel, the capillaries, and you can see here in healthy controls a nice color. But what happened in systemic sclerosis? In the finger capillaries do not move the red blood cells so well. The blood flow is lower, and you can see much more blue, both in the palm of systemic sclerosis and in the doors. So look the palm in normal condition, looking at the microcirculation and the microcirculation in the classical systemic sclerosis. And so the intensity is important and is evaluated with quantification that is quantify a perfusion unit. So how much faster capillaries move in the window of the laser beam. And you can see, you can evaluate, depend where you move the single laser speckle analysis. You can evaluate also the face of the patient and looking at the microcirculation on the skin, not deep evaluation, but skin. And here you see what happened when you treat with the prostacyclin the patient, for example. You can see the improvement, the increase of the skin circulation after 1 week of intensive intravenous administration of prostacyclin, Hyloprost. And you can see here the improvement here on the skin. Here is blue, and here is more green and yellow. So the microcirculation improved. And if you compare the normal capillaroscopy morphology with the normal analysis of blood flow in normal condition, good microcirculation and good morphology. But if you look in advanced sclerosis, you see angiogenesis to replace, but never happened that replaced, the fibrosis. So the morphology tell you that there are few capillaries and a lot of fibrosis, and the function tell you that the microcirculation in the finger is totally reduced, and here the risk of digital ulcer and even gangrene and so on, and amputation. So here in the middle, with the early and the active, you move slowly from the really normal to the really disease through different levels of damage. And you can, if you compare the laser with the single laser with the LASCAR, we have also the single laser, or the LASCAR with the microangiopathy score, or with the number of the capillaries, you see that there is a clear correlation. Less capillaries, less circulation, and so on in advanced conditions. So in psoriatic arthritis, we have almost the same problem, but here you can see much better the lesion with laser speckle. You can see here active lesion before the local therapy, and you see after local therapy the improvement of the active inflammatory lesion and the decrease of inflammation of the skin with decreased skin capillaroscopy. And you see here in active lesion, this is the active lesion you see here in the last, and you see in the picture, you see the angiogenesis that is characteristic of the capillaroscopy in the skin of systemic sclerosis. And then the fluorescent optical imaging was another proposal, but honestly, this implicates the intravenous administration of the fluorescence substance, and then you have to evaluate the distribution over time of the fluorescence. It's a nice, it's good, but the need of intravenous fluorescence and is in the cyanine green enhanced fluorescence may make some problem in some cases. Much more easier is the power Doppler ultra analysis. Then you can see here the power Doppler in the letter. This is the finger. You can see here the Doppler signal in the finger. This is the phalanx. This is the nail, and you see you can evaluate the blood flow in capillaries, as well as you can evaluate the here in the dorsum, the blood flow in the arterioles. We have just published a study comparing and looking at advanced systemic sclerosis, the arteriole blood flow, and is not reducing. So it's only a reduction of the capillaries, the blood flow, that you can evaluate in systemic sclerosis. And you can see here in the hand, this is the reason you have a good circulation, because you have big vessels. And here the reason why you have bad circulation in the finger or reduced circulation in the normal condition. And it's clear that when you analyze morphologically and functionally, you have the best evaluation, because you can cross the score of the number of capillaries with the cross of the perfusion unit that you observe with the LASCA or with the power Doppler analysis. Again, if you want to compare the different tools for the analysis of microcirculation, the time of execution is very important. And it is short with, of course, the infrared thermography, with the laser Doppler and laser Doppler imaging is a medium, very short with LASCA, very short with power Doppler ultrasound, a medium with fluorescence. And even interesting is when you compare to see at another aspect, that is the cost. With thermography is a very low, you have an idea, moderate with laser Doppler, moderate with laser Doppler imaging, but very high with the LASCA. So this is for high center with high sophisticated capability to evaluate their patient, and very high even with fluorescence with some risk. So in conclusion, just to try to draw the conclusion, we can say that, of course, the morphology and functional analysis of microcirculation should be combined. Now we are working with a company to have in the same device, in the same capillaroscope also the ultrasound to evaluate the blood flow. So to have at the same time when I see both morphology and function. And we will obtain this. And you will have at this point a complete analysis. It is important because you want to see if your therapy are successful. You want to see if your trial is correct. You want to see if the patient say that is improved, that is not, and vice versa. So it's important to have an objective. And plus the rheumatologist becomes strong in his institute, because finally the internal medicine, the vascular expert, the dermatologist, the diabetologist, and so on, dermatologist asks to you, what do you think about, can you do this evaluation? Tell me which is the situation. So it's an important tool in the hand of rheumatology. I suggest also in your wonderful country to do that, to invest the money. So here, thanking to my coworkers. These are some of the coworkers working in the labs, working in the laboratories, and thanks to Professor Smith that from Ghent, we have a cooperation of for more than 15 years. We have developed, you will see even other important studies. Now, I think we will do probably at the end of the discussion, but let to the moderator to decide. But in any case, I'm pleasure to give the talk and the words to Professor Vanessa Smith. Thank you very much.
Thank you. Thank you so much, Professor Cucciolo. Now,
this is silent is because nobody there?
There are a lot of people here. I think they just got stunned by your excellent talk.
Vanessa, can you hear me?
Thank you.
I can hear you.
So now we move on to our second
Probably
talk.
the moderator will say something.
Sorry, I didn't get what you said.
Probably you want to introduce Professor Smith.
Yes, I wanted to introduce. Our next talk is by Professor Vanessa Smith. She's the head of clinics Ghent University Hospital. She's an associate professor of rheumatology at Ghent University, Belgium, a chair of EULAR study group on capillaroscopy and microcirculation, and she will be talking on the NVC capillaroscopy patterns, optimization of the diagnosis, and scoring the microvascular damage. Over to you, Professor.
Thank you so much, Bilal. Please, can you all see my screen?
Yes, we can see your screen.
Before to start, thank you so much. Before to start, I would like to congratulate all of you with your silver jubilee and also with the 75th birthday of independence of your country. It's an extreme honor that I can be here, and it's also an extreme honor to be teaching at the side of Professor Cucciolo, the papa of capillaroscopy, who in fact taught me capillaroscopy, and with whom indeed I'm still collaborating from day to day. So today I would like to teach you something concerning capillaroscopy, the role of capillaroscopy in the presence of the Raynaud's phenomenon, and also very importantly, as Professor Cucciolo already said, to evaluate capillaroscopic images yourself. In this lecture, I will teach you, but please, after the coffee break, we will do interaction and I will ask you to evaluate images yourself, so please do pay attention. Let us start. So what will we learn in this lecture? We will learn to know the difference between a primary and a secondary Raynaud's phenomenon. We will learn that in a patient population with only the Raynaud's phenomenon at baseline, the disease that most likely to occur in the future is systemic sclerosis. We will know that the combination of a scleroderma pattern on capillaroscopy and a systemic sclerosis specific antibody is predictive for developing systemic sclerosis in a population who only has Raynaud's phenomenon at baseline. And then in the second part of this lecture, I will teach you how to standardly perform capillaroscopy. I will teach you the standard capillaroscopic characteristics. I will teach you what is the scleroderma pattern, because you already saw in the lecture of Professor Cucciolo, this is very important, and I will teach you what is the non-scleroderma pattern. I will also teach you that non-specific changes on capillaroscopy may occur in 34% of healthy controls. And I will teach you the scleroderma patterns of Professor Cucciolo, the early, the active, late, because we have several studies which show how they are related with more severe disease in systemic sclerosis. And I hope that after the end of this lecture, you will know that non-specific changes on capillaroscopy are not the same as a scleroderma pattern. On the bottom of this slide, you can see fast track algorithm. Well, this is something that Professor Kutulu and I constructed actually on a flight to Bangladesh when we were teaching in Bangladesh, and which is an algorithm which we will teach you in 10 minutes, and then afterwards do some exercises with you and ask us, when we show you pictures, to tell us if it's a scleroderma pattern or not. But this is for after the coffee break. So what is capillaroscopy? Professor Kutulu already showed you it's a tool to look at the microcirculation, and ideally we look at the nail fold of the fingers because this is the only place in the body where the capillaries run parallel to the skin surface. So you put a drop of oil on the nail fold, you put a 200 magnification, and this is very important. Zaira asked us, can we buy cheaper tools to do a demonstration? And I said to Zaira, no, you can't, because you need to use the 200 magnification, because you need to have standardized images which you can comment on and somebody else in the world can immediately understand what you're saying. So you use a 200 magnification, you put this on the nail fold, and immediately you see the images on the screen. I do promise to you that one day we will come to Pakistan and bring our 200 magnification tools. The main role of capillaroscopy is the early detection of systemic sclerosis in patients who present on your consultation with solely the Raynaud's phenomenon and no other signal of a connective tissue disease. As I said before, per consensus, this is a 200 magnification, and we evaluate finger 2 to 5 from each hand. After today, you will be saying to me, Vanessa, this is a perfectly normal image, a non-scleroderma pattern, but stereotype normal. You will be able to say, Professor Kutulu, this is not a scleroderma pattern. These are non-specific abnormalities. And after today, you will all be able to say, because we will test you, that this is a scleroderma pattern. Now, first, let me tell you what is the Raynaud's phenomenon, because I told you that it's very important to use capillaroscopy in a patient who presents to you with only the Raynaud's phenomenon. Well, the Raynaud's phenomenon is vasoconstriction, which is reversible, but which always is triggered by cold or stress. What we need to know about the Raynaud's phenomenon is that in the majority of cases, it's primary. Primary Raynaud's phenomenon makes up 90% of all cases of Raynaud's phenomenon. These are functional changes. It's idiopathic, and we have no underlying disease. Last century, Leroy and Metzer already proposed criteria which could easily be applied in clinical practice. And if you apply those, then you were correct in 82% of cases to say your patient would have a primary Raynaud's phenomenon. These criteria are the following. You should have strong and symmetrical pulses. You should have no evidence of digital trophic lesions. You should have a normal capillaroscopy read non-scleroderma pattern. And this is why it's very important that after today, you can say yourself when you don't have a scleroderma pattern. You should have a negative anti-nuclear antibody and a normal segmentation. Contrarily, secondary Raynaud's phenomenon occurs in 10% of all cases, and of course, it's very important to detect. You have structural changes, and recognition is important as this may lead to irreversible tissue damage. Of note, these structural changes is what we are looking for when we evaluate the nail fold with our capillaroscope. This is a patient with a secondary Raynaud's phenomenon and digital ulcers. In a patient population, as I said before, with only Raynaud's phenomenon, no other sign of connective tissue disease, if you follow up that patient for a long time, then most likely, if this patient will ever get a connective tissue disease, it's systemic sclerosis. Where do I get this from? Well, we have a very nice study by Koenig, which I would like you to read this weekend. Koenig evaluated 580 patients who were referred to an academic center in Canada. Those patients only had Raynaud's phenomenon at baseline. After 10, 15, and 20 years of follow-up, he checked if they developed a connective tissue disease. 13.6 out of which 12.6 got systemic sclerosis over time, and only 1% got another connective tissue disease. So this is why we always screen for systemic sclerosis when we have a patient who only presents with Raynaud's phenomenon at baseline. What does Koenig teach us? And this is already a key point for today. Koenig taught to us that if you have Raynaud's phenomenon and not a scleroderma pattern, and not systemic sclerosis specific antibodies, that your chance to get systemic sclerosis is almost zero. It's 1.8% over 20 years. This is the importance of this study, and this is the importance of recognizing the scleroderma pattern or not. This algorithm had a very high negative predictive value of 93%. This means that you're correct in 93% of cases where you say to the patient with Raynaud, but no scleroderma pattern and no systemic sclerosis specific antibody, that he or she is safe. Contrarily, the Koenig algorithm also showed to us that if you have Raynaud's phenomenon, but a scleroderma pattern on capillaroscopy, and systemic sclerosis specific antibodies, that you have a very high chance to transition to systemic sclerosis. After the lunch break, and after the coffee break, sorry, we will teach you the fast track algorithm and make you do exercises yourself. So we will need a microphone in the room so you can reply to our questions. Why? Well, because as I said, the scleroderma pattern is also integrated in the 2013 ACR Euler classification criteria for systemic sclerosis. And Professor Coutelot already hinted at this today. We have 3 scleroderma patterns. I'll tell you now, but you will gradually learn it throughout this lecture. We have an early scleroderma pattern in which you have giants. Giants are capillaries with a normal shape, a hairpin shape, but an apical diameter of at least 50 micrometers, and you can see them measured here, these apical diameters. In an early pattern, you have giants. In an active pattern, logically, as systemic sclerosis is a disease with obliteration of the microcirculature, you have loss of capillaries. Between these green lines, you see linear millimeter, and you will see that you have a lower density. We will learn to count the number of capillaries. A lower density combined with giant capillaries and hemorrhages is called an active pattern. And the last pattern of Professor Coutelot I would like to teach you is the late scleroderma pattern. A late scleroderma pattern consists of a very low number in a linear millimeter and totally abnormal shapes. In fact, this shape, which Professor Coutelot calls neoangiogenesis or abnormal shapes, is totally not the shape of a hairpin. Why are these patterns so important? Well, as Professor Coutelot already hinted at in his lecture, we have several studies, and recently also in rheumatology, a multi-center study to show that these patterns can predict who will have severe organ involvement in systemic sclerosis. So with this introduction, I would like to start and to tell you what are the capillaroscopic parameters to be evaluated and what is a scleroderma pattern. Importantly, standardization of description of what is seen by capillaroscopy is very important, and this is why we will teach this to you. When I started with capillaroscopy in 2006, we had different definitions in different schools. In Germany, a tortuous capillary meant something different than in France or in Italy, and this was very confusing. And this is why Professor Coutelot decided to select an Euler study group and to start first of all with standardization. And this is what I will teach you in this very lecture. I will teach you that as capillaroscopic characteristic, what I want you to describe in your protocols and when you do studies is density, which is the number of capillaries in a linear millimeter. Dimensions, I already told you that we measure a dimension apically. The number of abnormal shapes or neoangiogenesis, and the number of hemorrhages. Based on these characteristics, we can classify an image as a scleroderma pattern, as you can see here, or a non-scleroderma pattern. And I will teach you this gradually. And after the coffee break, we will teach you in 10 minutes a fast track algorithm to fastly discern if an image is a scleroderma pattern or not. So let us start by our capillaroscopic characteristics. The first characteristic is density. Density is assessed with a 200 magnification in a linear millimeter, and the systems Professor Kuttele showed you can easily place between the green lines 1 linear millimeter. And you always count the capillary heads that are lying closest to the nails. So let me do that on this image. I see 1 capillary here. I see 2 capillaries here. I see 3 capillaries here. I see 4, 5, 6, 7, 8, 9, 10, and 11. A normal number of capillaries in a linear millimeter should be at least 7. The second capillaroscopic characteristic we always must report are dimensions. Here you see a capillary, and an ideal capillary has the shape of a hairpin. A dimension is measured apically. Number 2 here is an apical diameter. On this image, you also see this. This is the width. In older studies performed with dermatoscopes, with lower magnification, sometimes they use the width of capillary. Don't confuse this with apical dimension. What we report in standard reports is the apical dimension. And here again, you see a capillaroscopic image, which is normal. Here you have an apical diameter of 38 micrometers. A normal apical diameter should be between 20 and 50, less than 20 micrometer. When it's between 20 and 50, we call it a non-specific abnormality, as we have in this image. It's an apical diameter of 38 micrometers. It's a non-specific change of dimension. This is not a scleroderma pattern. This was very confusing for me in the beginning, and this is why we made the fast track algorithm. So this is a non-scleroderma pattern. You have a non-specific abnormality of dimension. Let us compare it to this image. In this image, I count 1, 2, 3, 4, 5, 6 capillaries in the distal row. And I also see that the apical dimension is more than 50 micrometers. It's 65, 48. Well, this is what Professor Kuttele tried to point out. A giant capillary is always pointing out to a scleroderma pattern. And as I mentioned before, the combination of giant capillaries with some loss of capillaries, what does it mean, loss of capillaries? Less than 7 per linear millimeter, and here we counted 6, is called an active scleroderma pattern. You see some brown dots here. These are hemorrhages. An active scleroderma pattern is a combination of giants, hemorrhages, and a lowered number of capillaries less than 7. So this image on the right is a scleroderma pattern. The third capillaroscopic characteristic which I would like you to describe in your protocols are morphology. Normal shapes are hairpin shapes. Our shapes with our torches, this means that the afferent and efferent line can undulate. Our third normal shape is crossing. Here you see that the limes cross once, and here you can see that the limes cross 2 times. We have done some reliability studies with this definition for normal, and we saw that we didn't have an optimal interrater reliability, and this is why Professor Kuttele added a fourth criterion before you can call a capillary normal shape. The tip must be per definition convex. And if you add that criterion to have a normal shape, then you have a very high inter-rater reliability, and this is what you need when you want to execute studies with a tool. So let us look at some shapes and decide together if they're normal or not. Well, in this image, I see here a hairpin shape, like this one. This is normal. Here also, but this shape with the dollar sign is not one of these three shapes, so I call this an abnormal shape. And this shape has a tip which is not convex, so it's also not a normal shape. Again, this shape here, or this shape, is totally not a hairpin, totally not a tortoise, or totally not just crossing once or twice. So these are abnormal shapes. This image on the left side has a density of 1, 2, 3, 4, 5, 6 capillaries. It has normal dimensions because if I would measure the apical diameters, it would be less than 20, but it has some abnormal shapes. This image shows non-specific abnormalities, but is not a scleroderma pattern. It can occur in you, it can occur in a patient with lupus. It's not a scleroderma pattern. But this image on the right-hand side has something very specific. It has two shapes which are not normal. This doesn't look like a normal shape. This is what Professor Cutolo calls neoangiogenesis. It's an abnormal shape, and this is also an abnormal shape. When we look in the linear millimeter, here you can see the green lines, we only count 2 capillaries. And I have told you in the beginning that a normal number of capillaries, a normal density should be at least 7, but here you can only see 2. So you have the combination of a lowered number of capillaries, only 2 capillaries, and they are abnormal shapes. This is a specific pattern, it's called the late scleroderma pattern. An extremely lowered number of capillaries, and they are abnormal of shape. This is a scleroderma pattern. The last capillaroscopic characteristic I would like you to know are hemorrhages. Hemorrhages, as I will show in the next slide, can occur in a healthy population, but only 5% of healthy controls. And then they should be always punctate, like you can see here, dots. Hemorrhages, as I will show you next slide, can also occur in scleroderma pattern or in any connective tissue disease. And this is why we call hemorrhages non-specific changes, because they can occur in healthy connective tissue disease and systemic sclerosis. Of note, this is an active scleroderma pattern. You have giants. Dimension has an apical diameter of more than 50. You have a lowered number of capillaries. I count in this 1 linear meter, 1, 2, 3, 4, 5, 6 capillaries, that's less than 7. Combination of giants, hemorrhages, and a lowered number of capillaries is an active scleroderma pattern. As you can see here, you have giants and a lowered density and the presence of hemorrhages. This is an old study, a very interesting study by Cabascal. Cabascal evaluated normal people, patients with systemic sclerosis, patients with lupus, and patients with undifferentiated connective tissue disease. And Cabascal could attest that punctate hemorrhages, less than 2 per finger or more than 2 per finger, occurred in 5% of healthy controls, but equally occurred in higher prevalence in any connective tissue disease, whether it was lupus or systemic sclerosis. Cabascal was also the first one to show to us that large confluent hemorrhages occur never in healthy controls. But again, large confluent hemorrhages can occur in any connective tissue disease, whether it's systemic sclerosis, lupus, or UCTD. Hence, we call them non-specific changes. So, until now, we've learned what is a scleroderma pattern. We have learned that if Raynaud's phenomenon occurs as only symptom without another symptom of connective tissue disease, we always must screen for systemic sclerosis, and that the scleroderma pattern combined with systemic sclerosis-specific antibodies are predictive to develop systemic sclerosis. We've also seen how to standardly evaluate capillaroscopic characteristics: density, number of capillaries per linear millimeter, the green lines; dimension, we measure the apical diameter; morphology, we have seen 3 normal shapes: hairpin, tortuous, and crossing, but the tip must be convex. And we've seen normal shapes which do not meet the criteria to be normal. And lastly, we've seen hemorrhages. We've seen the early, active, and late scleroderma pattern by Professor Cutolo. And now we have a question. We know that Raynaud's phenomenon occurs in healthy controls, and Raynaud's phenomenon can also occur in connective tissue disease. A person with lupus may have Raynaud's phenomenon. We can question ourselves, is capillaroscopy distinctive between healthy controls and other connective tissue disease? Because we have a predictive algorithm to discern systemic cirrhosis from a normal population, but do we have distinctive characteristics between connective tissue diseases and healthy controls? We don't have them. Why? Well, perfectly normal images and non-specific abnormalities can occur in healthy controls and in any connective tissue disease. Luckily, we will show you in a slide a study by Andrade, who tells us when an image is unlikely to belong to a healthy control. And this is what I would like to show to you. Andrade evaluated in Brazil 800 healthy controls. And Andrade could attest that changes occurred in healthy controls. In fact, 34% of you people in the room have one or another non-specific abnormality. But Andrade taught to us that 25% of all of you in the room may have a single abnormality, lower density, or a change in dimension. But only 8% has 2 types of abnormalities together. And only 1% of the 800 healthy controls that he evaluated in Brazil have 3 types of anomalies together. So if you see this image, in which you have in between a linear millimeter a lower density, but no other abnormality, so this is only an abnormality in density, this may still belong to a normal healthy population. But if you see this image, and this is an image of Professor Cutolo, and we will tell you after the break why this is a very important image, but in this image you have the combination of hemorrhages and changes of dimension. These are 2 types of abnormalities together. This is already less likely to be belonging to a healthy control, because the study of Andrade, who evaluated 800 healthy controls, showed us this only occurs in 8% of healthy controls. So we've seen in the second part that an abnormality in one or the other characteristic can occur in a healthy control population, but several types of abnormalities together is very unlikely to occur together. So, for your Jubilee, I would like to go over 2 pictures with you. And Professor Cutolo didn't see these 2 pictures, so he can also comment on these pictures. Already in the room, I would like people to comment on this image. Sarah, Bilal, or anyone in the room who wants to comment on the number of capillaries in the linear millimeter. Here, the linear millimeter is demarked by 2 blue lines, and also the apical diameter. Please, can anyone comment to me?
6 to 7. The density is 6 to 7.
Yes, I count here 1, 2, 3, 4, 5, 6, 7, 8, 9. I have 9 capillaries. Yes. And what about the apical diameters?
Non-specific.
Yes. They should be 20 micrometers, but they are 30 and 42.
Yeah, so they are normal.
Yes.
They are normal. So 20 to 50 is non-specific.
Pattern.
Non-specific, because a normal should have
Less than
20
20.
micrometer.
Less than 20.
Yeah. And I will show you now to whom this image belongs. First of all, I will tell you something. After the coffee break, we will learn the fast track algorithm, and with the fast track algorithm, we will say this is not a scleroderma pattern. But recently, just some weeks ago, Professor Coutelot published a very important paper in which he evaluated all his images retrospectively and could show that this image is called a prescleroderma pattern. It's something very hot and very new. A prescleroderma pattern consists of images with more than half of the image with apical diameters more than 30. And these images are very worrisome to us because in the end, they will also develop to a scleroderma pattern. But this is just a side note. What you will have to know today is that indeed this is non-specific abnormalities. But let me show you to whom this image belongs. We got recently in our hospital a male of 50 years old, Asian descent, but no relevant medical history. He was a cook. And the 13th of September, he got onset of cough and mild fever. The 26th of September, he went to the emergency department in a peripheral hospital with some ground glass opacities on chest CT. And as a working hypothesis, they had viral pneumonia. The 2nd of October, he came back to the emergency room with an extreme desaturation, 30%, urgent intubation, and then they transferred him to our university hospital to the intensive care units. 2nd of October. By the 5th of October, we found he was anti-MDA5 positive. We started high-dose steroids and plasmapheresis, but we lost him. And this was his image on HRCT. Why I put this clinical case in here to show you what Professor Coutelot told you in his first lecture. It's very important to have nilfold cup, because when he was in ICU, we went and performed this capillaroscopy, and we immediately knew this was fishy and not just a normal viral pneumonia. Just to show you how even in Europe nowadays, we lose people because they don't think about rare connective tissue diseases such as inflammatory myopathy, related interstitial lung disease. So I do fully second Professor Coutelot telling us we need this tool in daily practice because we can help our people of internal medicine. Just one other second clinical case, and you will tell me again what the image is, and then we will go to the lecture of Professor Coutelot on pregnancy and COVID. This case I just showed you was a rapidly progressive interstitial lung disease mistaken as a viral pneumonia in a peripheral hospital, but capillaroscopy immediately showed us when he was transferred to us, but already intubated, that it was an anti-MDA5 positive dermatomyositis. And as Professor Coutelot hinted at in his first lecture, the brother and sister diseases of systemic sclerosis, such as inflammatory myopathy, mixed connective tissue disease, all have elements of scleroderma pattern in their capillaroscopy.
Yes, this is the problem.
Does anyone want to comment on this image in the room, please?
So, if we now start counting the capillaries, I can count 1,
Yes.
2, 3, 4, 5. So then there is like a fallout. So I hardly can make out any capillary over here. So yes, but
I can, because this is for me also capillary, but an
Okay.
abnormal shape.
Fine.
Because you don't have a convex tip, but you have an undulating tip, okay?
Fine.
So 6,
7,
here,
8,
7, 8.
7, 8.
Perfect.
So this is again then because we can see hairpin and we have just a crisscross kind of a capillary. So with the dimension, so what is the dimension of this capillary to which you are pointing? So
it will be
apical
less than
dimension.
20. Here it will be less than 20. Yes?
Less than 20. So it is a non-specific, it's a normal pattern or a non-specific. It's
Normal
yes. When I went in 2007 to the department of Professor Coutelot to learn capillaroscopy, he would immediately say, well, these are some abnormal shapes here. This smells like lupus. Never in lupus we were able to have a specific pattern. But I showed this to you because we got this lady recently sent to us by dermatology. She did have some rosacea, but she also had a butterfly rash with sparing of the nasolabial folds, and she had an anti-dsDNA. So this lady had a lupus. Just to show you, this is a non-specific pattern, as you correctly said, and this pattern belonged to a lady with lupus. I would like to thank you so much for listening to this first lecture on how to standardly evaluate capillaroscopy. You see it's fully immersed with the scleroderma patterns of Professor Couturlo, and I'm so happy that you were able to use counting the density, the dimension, and the abnormal shapes to classify images. Now we will have another lecture of Professor Couturlo, then we will have a coffee break, then we will teach you the fast track algorithm to fastly discern a scleroderma pattern from a non-scleroderma pattern, and then you will do 10 exercises with the room together. Thank you so much for your attention.
Thank you, Professor Couturlo. Thank you, Vanessa. So we'll be back, I think, within 15 minutes.
So much
we're going to be back. So 10 minutes break.
Thank you
I think
so
it's
much.
first a lecture of Professor Couturlo now on pregnancy and COVID, and then we have a coffee break.
Yes, thank you so much. It was such an enlightening and inspiring talk. Now we move on to the last talk of this course, and then we'll have the quiz. This talk is by Professor Maurizio Couturlo. He's the Professor of Rheumatology and Internal Medicine, Director of Lab and Experimental Rheumatology and Academic Division of Clinical Rheumatology, Director of Postgraduate School of Rheumatology, University of Genova, Italy, and he'll be talking about new advances in capillaroscopy, the patterns in pregnancy, and COVID-19 survivors. Professor Couturlo.
Thank you, Bilal. Thank you to all of you that you follow so carefully our, can I say, suggestion and experience. Now, this is a really new topic I will present to you because there are not any more data. There are some data, you will see. Some of them arise from our experience. I don't know if you see already you can see the screen. If you say, yes, I go. And can you see that?
Yes, we can see that.
Thank you very much. So, two different conditions, pregnancy and COVID. But this is just to show you how the nomenclature that Vanessa Smith presented, we presented, can be partially applicated, of course, in many other conditions. And new idea, new experiences arising, for example, in pregnancy. Let me start with pregnancy. Pregnancy, of course, is a very complex condition. And we know that the process, I can say, of pregnancy implicate also some immunological changes in order to defend the fetus, as well as, of course, metabolic, circulatory changes, and so on. So it's clear that there is a microvascular remodeling that is responsible for the vascular adaptation to pregnancy. And the evaluation of the microcirculation with capillaroscopy that I present to you, but we just published a few months ago, you can find on PubMed, try to see what happened during the pregnancy, before, after 1 trimester, 2 trimester, the 3rd trimester, and in the postpartum, if there are some changes. And then we will present also very early, not yet published changes we can observe during pregnancy in autoimmune disease. So it's clear that this study implicates a little care for the pregnant people. Capillaroscopy is not invasive, of course. We told you just a microscope, so we can do this very safely and easy for pregnant women. And we consider 30 healthy pregnant. And 30 non-pregnant age-matched healthy women were considered at the same time to see if they're the same age. In this frame of time, many changes may happen, or which kind of change may happen with so-called not specific abnormality that Vanessa Smith mentioned. So is here the mammographic general obstetric anamnexis of the patient considered, and that the images were evaluated from the qualitative point of view, so the patterns, and semi-quantitative assessment, so giving a score, just to see if any possible change observed in pregnancy should become something very significant and a marker, a microvascular marker of the vascular adaptation in pregnancy. So the outcome of the population during this study was a longitudinal study, was quite good. No major problems during the pregnancy of these 30 ladies. And you can see the evaluation was done at any level, particularly considering also the microcirculation, blood pressure, for example, or the evaluation, you will see later, other parameter, placental pressure and so on. And important the postpartum evaluation to see if the changes eventually should be observed are reversible after pregnancy, so are related to the release of growth factors like vascular endothelial growth factor and many other growth factors that are associated with the pregnancy, of course. And pregnancy, as we discussed, is a really important vascular test for the mother. And we know what happened, unfortunately, in some pregnancy when the circulation gets some serious problems. So the results what show it. This was one of the most interesting aspects, a progressive and significant increase of the angiogenesis. At the same time, a specular reduction in capillary dilation. This was significant. So a progressive, significant increase of the angiogenesis and a progressive reduction, as you can see in such picture, of the dilation during the 9 months, and even if you add the postpartum. So you can see the progressive increase of the non-specific but classical aspect of angiogenesis during the trimesters of the pregnancy. And if you look more carefully in the detail, you can see here the angiogenesis, you can see the length of the capillaries, you see the width of the capillaries, so you have an idea, 1 linear millimeter, what is going on during a normal pregnancy during the progression, increase of angiogenesis. And this maybe reflect also what happened in the placenta, because it's clear that intensive angiogenesis is present in the interface between the fetus and the mother in order to create for the fetus the best condition to grow and to receive the nutrients. So angiogenesis is reflected by capillaroscopy, as you can see here. But also interesting that such kind of change, of course, were not observed in age-matched controls. The parameters were stable, even if it's the same age, young women with menses every month, with changes due to the classical menses process with increase of estrogen, progesterone, and so on, but no changes at the level of the microcirculation. I would just remember that before you get in important changes that you can detect in 1 millimeter, need months, not just days, at least. So a significant correlation, and I mentioned to you the placental and in particular the blood pressure, was found a significant inverse correlation between the intensity of the angiogenesis and the systemic blood pressure of the mother. So a real adaptation that is related to the distribution of the blood in more vessels, in more areas, and the capillaroscopy observed that. So in details, you can see that this increase you can see during the 3 trimesters. You can see the values, the significance. you look at the angiogenesis in terms of mean and in terms of absolute number of angiogenesis. And you can see the significance, the p-values is 0.01, so very strong. And the same was not found, as I mentioned it, if you look at the 3 trimesters in the control, absolutely not. But if you compare the significance of the change, increase on the angiogenesis, decrease of dilation, you can see that versus the pregnant women, this difference, of course, is significant. So at the end of the story, you reflect with the capillaroscopy, and you can use the capillaroscopy if you want to look at the intensity of the change, in particular the intensity of the angiogenesis that is related, as I mentioned, to the vascular adaptation that happened during normal pregnancy. We have some data, very early data, in what happened in patients with autoimmune connective rheumatic disease. For example, look here, you have the disease we have evaluated, including the antiphospholipid syndrome, overlap syndrome, FCTD, UCTD, and you can see here in rheumatoid arthritis, for example, very limited changes, no disease-specific alteration, excluding a slight increase of the angiogenesis that's observed also in normal pregnant, and in the post part of evaluation, you see some small hemorrhages. What in systemic lupus? And this is very interesting aspect. I mentioned it to you in the first talk, the presence of the comb-like pattern, so minimal and parallel microthrombosis and microhemorrhages. This patient was, during the first trimester, characterized by the presence of anticardiolipin antibodies, and here the signal of the microthrombosis. But you can say that the real change was again, even in systemic lupus, and this is characterized in normal pregnancy, on increase of neoangiogenesis, still observed. It's clear that in presence of IgM, anti-beta-2 glycoprotein, you can observe this classic comb-like arrangement. And this is interesting because maybe you don't realize in this patient that she was moving in a comorbidity, and doing the capillaroscopy very safe because it's just a picture. You realize, and you went probably, if no clinical sign to symptoms, to look at the concentration of IgM anti-beta-2 glycoprotein. So would be interesting to evaluate the state of microcirculation during pregnancy. I told you is totally safe and not dangerous. Here we have in systemic lupus, but we have also in undifferentiated connective tissue disease. This is a very overlap condition that you know may evolve in different direction and in mix different aspects of autoimmune connective tissue disease. And here we observe the scleroderma-like. I will spend some word about this, but already I told you the scleroderma-like pattern was observed in these patients in second, first, third, and fourth fingers of the right hand. And you can see at the second trimester, at the third trimester, and in the postpartum. It's very interesting that in some diseases, like in rheumatoid arthritis, pregnancy is a sort of therapy for the patient. And you know very well that 60% of pregnant rheumatoid arthritis patient may improve during pregnancy, may improve because of the increase of corticosteroids, testosterone, progesterone, and this is a sort of steroid bolus that improve the course of pregnancy. But let me show you another aspect. Here you can see, for example, these abnormal shapes that were also changed, and in any case are associated with this vascular remodeling. But very interesting is the mixed connective tissue disease that is much more complex. And you can see here preconception. The patient was affected by MCTD. You see a scleroderma-like pattern with together giants. You see angiogenesis, loss of capillaries, microhemorrhages. You see classical scleroderma-like, and this is typical for such kind of patient. But the antiphospholipid syndrome, again, you can observe again some interesting changes that change in the postpartum. In some, they improve. So in few words, if you want to conclude, we can say that capillaroscopy variation during gestation provide an argumentation to follow the microcirculation in pregnancy, because especially and we will publish a larger paper, in a patient with autoimmune rheumatic disease, and the progression and the change may be very important to be observed and added to the follow-up of the patients. Okay, and now we move to very materializing, and so the capillaroscopy in active COVID, active patient during the COVID, in patient, and in survivors after they got the COVID. We know that COVID is characterized by an intensive dysfunction of organs, and we know that also that COVID is characterized by a recent autopsy-based study on an endothelitis and damage of endothelium that enters small and medium-sized vessels in more than 90% of patients with COVID. So thrombotic events, but are in 30-60. But endothelitis, so damage endothelium in COVID is in 90%. So it's clear that endothelium is involved. But few data are available up to a few months ago about the capillaroscopy in COVID. And we know that the virus, the SARS-CoV, bind directly to the receptor endothelial cells and use this binding to penetrate, to damage the endothelium, to induce prothrombotic, pro-inflammatory events, to induce the production of immune cells, of cytokines. So the severity of the disease aggravates. And we saw with the capillaroscopy now interesting aspect. Let me start with the first study, because we know that this cascade of the event that is classically evident during the cytokine storm, we can really observe these changes. There are some studies that suggest that not to do capillaroscopy in acute patients, because then the device must be very clean and disinfected, because it's the risk to bring the virus outside the room of the patient. So there are some guidelines. There is a paper dedicated to the management of the capillaroscope in case of infectious patients. But in any case, this is the first study published 10 months ago, looking at the changes observed in COVID patients. COVID patient, looking at the presence of possible changes, scleroderma, no scleroderma pattern. Let me show the data. In any case, clearly in all patients with acute disease, a reduced capillary density was observed in 50%. But in acute patients, so in patients during their recovery, the increased presence of hemorrhages with hemocysteine deposits, result of macrohemorrhages, and microthrombosis. This is characteristic of the endothelitis in COVID were observed. While in the recovered patient after discharge, not in acute phase, after, you will see, usually we consider 3 months, a larger prevalence of larger capillary dilated, but particularly the loss of capillaries was evident. So in few words, we are using the same data that characterize the damage in autoimmune rheumatic diseases. At the beginning, macrohemorrhages, damage of the capillaries, they are broken, release the red blood cell, and they collapse and they disappear. Like when you smoke a cigarette, the smoke, you burn the cigarette and then the cigarette disappears. And this is the loss of capillary, the fate of capillary. So capillaroscopy tells us that it's increased damage of the microcirculation in COVID, and with the capillaroscopy, we can observe the three most important aspects that may be observed in the acute phase, but also in the post-acute phase with a different characteristics, of course, and this difference is statistically significant. This is our study that evaluated in a very complex manner versus control group of primary renal phenomenon, control group with patient with healthy control, age and sex matched, in order to exclude non-specific abnormality that normally we observe also in healthy. And you see that we considered survivors that got a mild or moderate disease, but also patients with severe disease. How to classify mild and severe? Survivors with mild, no need oxygen supplementation or Venturi mask. Survivors with past-severe COVID, continuous positive airways pressure, and mechanical ventilation. So survivor from severe and less severe disease. What is the wound in the microcirculation? And here you see that following the nomenclature that we discussed today, we observed, for example, that the absolute number of capillaries was significantly reduced in severe compared to moderate survivors, and both in primary renal phenomenon and control subject. This is a very important point. So the damage of the microcirculation COVID, much more intensive COVID, much more you will have some problems in the microcirculation that is associated, as you know, with increased fibrosis when you have a pneumonitis. So in the lung, you have less vessel and more fibrosis. That is the terrible insufficiency, respiratory insufficiency, if not adequately treated patients, and they will need the oxygen and even after the discharge. So important, the absolute number of capillaries that you see in the nail fold, but is in all the body, including the lung. And if you want, consider also the isolated microhemorrhages. This compare, like in the previous study, to the acute in the recovery were less significant, less important than even primary renal phenomenon. So what means that microhemorrhages are a marker of acute endothelial damage, acute endothelitis in COVID, acute damage of microvessel in early systemic sclerosis, and so on. Hemorrhage is the smoke of the cigarette. Finish the smoke, the cigarette disappear, and you lose capillaries. So there is a physiological, a rational consequence. First, the damage, dilation, then explosion of the capillary, release red blood cells, collapse of the capillaries, and then the capillary disappear. Now you understand why we count the capillary. This is the final marker of this sequence: dilation, hemorrhage, disappearance. And what happened in COVID is exactly the same. So it's important that also we observe that not induce a statistical significant effect of the strong therapy during the COVID, IL-6 blockers or glucocorticoids or heparin, no change. But there was a trend that we will test in the larger number of patients. This test tells us that patients that got a stronger anti-inflammatory immunosuppressive therapy from the beginning got better. So we can say that there is another study that evaluated the microcirculation in the patients on the doors and the nail fold level during the acute phase of the disease, and again after 3 months during the recovery. This is our demographic characteristic of this study. Again, you see the concentration of C-reactive protein, D-dimer, important marker of the microthrombi or problem on coagulation. And the ferritin also another important marker. And where search the correlation between the number of capillaries and the presence of microhemorrhages and an angiogenesis. And all of such damage, again, microhemorrhage and angiogenesis thrombosis, were not anymore detected after months after the acute phase. So that means that the signal of the endothelitis and damage is reduced when you see the patient and the patient recover. Reduction of the cavity. On the other hand, in any case, you observe the late consequence of the damage, the loss of capillaries. So microhemorrhages, tentative of create again capillaries, microthrombosis, acute phase. Smoking the cigarette, reduction of capillaries, lower number of capillaries during the recovery. You can see how statistically significant was this difference. So there is a direct correlation between capillary density during acute phase and lymphocyte number, just to enhance the role of lymphocyte in production of cytokines and any other mediators. But there is a direct correlation in the acute phase between the acute phase reactant, in this case, C-reactive protein. And so you can see here the correlation is significant. Much more inflammation you have, much more signal of acute damage you have, less inflammation, less acute, less signal of damage, hemorrhages, dilation, and so on. So the number of capillaries, you can see even the association, the correlation with the max ferritin median levels. And the conclusion is what I already told you, that we have an acute phase in every disease. We have the marker with the capillaroscopy, microhemorrhage, dilation, any other strange, possibly neoangiogenesis when you have a very active disease like dermatomyositis. But then at the end of the story, for all the disease, in the recovery or in the progression of the disease, the number of capillary decrease. This is the real final marker. But let me tell you something in children with COVID. This is a brand new. The capillaroscopic change in children. Children have the COVID, of course. And here 31 children, 21, 30 with the infection and 21 with the real disease, and 6 as a control with the multi-system inflammatory syndrome. This is the new syndrome observed in children versus 58 healthy controls with careful analysis of microhemorrhages, loss of capillary angiogenesis. What was observed? Was observed that if you consider the marker of inflammation were very high, like in the previous study, like we know happened in COVID. So strong coagulation increase, strong inflammation. But interesting that was increased the angiogenesis, the microhemorrhages, and so this was significant during the acute phase, also in the baby, compared to the patient group with where present capillary density reduced and the distance between the capillary, the same thing to say the avascular areas, loss of capillaries. So versus the multisystemic syndrome, the frequency was much higher in this form. So maybe in the future should be capillaroscopy useful to diagnose this new syndrome. So we can conclude now, because it's time for coffee or tea break. Reduction of peripheral capillary number observed in COVID survivors, but also in patients with acute form, reinforce the reports that report a lower microvascular density in different peripheral body districts, not just in the finger, but in the eyes, in the skin, in the tongue, after SARS infection. And maybe this is one of the reasons of the symptoms, loss of the taste, loss of the perception that have patients for long due to the loss of capillary, at least in some of them. The nomenclature is mutuated from the literature, the nomenclature in rheumatology, and the hyperinflammatory status in COVID explain this change. But no any one of the study was able to find a real COVID-19 pattern on nasal capillaroscopy, excluding the nomenclature I mentioned. And no drug was up to now to influence this progression, although some interesting and that should be evaluated suggested antivirals and anti-IL-6 receptor antagonists may decrease the consequence of the altered microcirculation. Okay, thank you very much. Again, my co-workers and Vanessa Smith from a lot of time co-working with us. And thank you for your patience and time that you spend with us. Thank you very much.
Thank you. Thank you so much, Professor Cucciolo. Now, before going on to the next quiz session and session with the participant, let's just take a short 5-minute break, and then we'll get back and start with the quiz.
Bilal, just a point of... Bilal?
Yes.
Do you hear me?
Yes, I can hear you.
Thank you. Before we have the quiz, we first have the instruction of the quiz,
Okay.
which is the fast track algorithm, which will take 10 minutes. And with that, they will be able to do the quiz.
Okay. So first we'll
Wonderful.
have a break of 5 minutes, then we'll have introduction to the fast algorithm, and then we'll have the quiz. Is that okay?
Wonderful. Perfect. See you soon. Bye-bye.
Thank you. So I think every one of you has taken a break. So please get back to your seats so that we can resume the session. Now we move on to the last part of this capillaroscopy workshop, and if everyone of you is ready, we can start. I'll request Professor Smith to start first giving a, just a detail about FAST algorithm, and then we'll move on to the quiz. Over to you, ma'am. Professor Vanessa, you can start. Can you hear me? Can you hear me?
So
Can you hear me?
I think, Vanessa, your mic
Yes,
is actually,
she's
I think, off.
starting.
So with-
Professor Vanessa, you can start. We cannot hear
Yes,
you.
can you hear me?
Yes,
Can you hear me?
now we can hear you.
Wonderful.
Thank you.
Wonderful.
Now you can
Thank you
start.
so much.
Welcome.
Can you see my screen?
Yes, we can see your screen.
Thank you, dear colleagues. Thank you so much for being here. These 10 minutes, I will teach you the fast track algorithm, and then we will do some exercises together. So we have seen in the last lecture that we analyze the following capillaroscopic characteristics per consensus: density, dimension, abnormal morphology, and the presence or absence of hemorrhages. We have seen that on the combination of these characteristics, we can classify an image as a scleroderma pattern. We have seen the early, active, late scleroderma pattern, or a non-scleroderma pattern. We've seen perfectly normal images with hairpin shapes, more than 7 in 1 linear millimeter, but we have also seen in last lectures some non-specific abnormalities. For example, an apical diameter which is larger than 20 micrometer, or the presence of an abnormal morphology. This enormous variability of non-specific abnormalities is sometimes very challenging for the non-expert capillaroscopist. When I started capillaroscopy, sometimes when I saw an image with one or the other non-specific abnormality, I was worried to say it's not a scleroderma pattern. And this is why with the Euler study group, we've created a fast track algorithm to fastly differentiate an image as being a scleroderma pattern. That's very important when we have a patient with Raynaud, because it has a predictive value for systemic sclerosis, or a non-scleroderma pattern. We have proposed a fast track algorithm, and then we have assessed its inter-observer reliability. So I would like you to take a picture of this image, and then you will use this image when we do the exercises. The fast track algorithm has 3 rules. Rule number 1, if your density, your number of capillaries between a linear millimeter, is 7 or more, and if you do not have giants, then you may safely classify your image as a non-scleroderma pattern. Rule number 2, if you do have giants, or if you have the combination of an extremely lower density, 3 capillaries or less in a linear millimeter, and if all of them are abnormal, then you have a scleroderma pattern. So then your image that you have in front of you is a scleroderma pattern. If your image doesn't meet the criteria for rule number 1 or rule number 2, then you can automatically classify it as a non-scleroderma pattern. This is rule number 3. So let us do this together. In this image, I see my 1 linear millimeter demarked by 2 green lines. I count 1, 2, 3, 4, 5, 6, 7, 8 capillaries in a linear millimeter. So in this image, my density is more than 7. I don't have giants because all my apical diameters are even less than 20 micrometers, so I automatically classify it as a non-scleroderma pattern. This was an image which was in the beginning difficult for me because I count the lower density, 1, 2, 3, 4, 5 capillaries. But let us use the fast track algorithm. Does my image belong to rule number 2? No, because my density is only 5, so it's not more than 7. Does it belong? Yes?
Vanessa, may I hold you for a second over here? So the capillary
Yes,
loops which are at the base, are we not supposed to count them as well? So,
no. Thank you for this very interesting question. We always count the capillaries, which are, this is the nail, which are, and here you see the papillae, you see this white halo?
okay.
This is the papillae. You always count the capillaries which are closer to the nails. And an easy rule of thumb is you have some capillaries lying next to each other. You look at their width and cut them in half. So if I do this here at the screen, this is my average width. I cut this in half, and all the heads that are lying above that I count. So I count this one, but I don't count this one.
Okay, fine.
Does that reply to your question?
Got it. Thank you.
Wonderful. Okay, so let us continue. In this image, we counted 5 capillaries. It doesn't belong to rule number 1. It doesn't belong to rule number 2 because I don't have giants. All my capillary diameters are less than 20 micrometer. And I also don't have less than 3 capillaries, so it doesn't belong to rule number 3. This means it belongs to rule number 3, which says you can automatically classify it as a non-scleroderma pattern. You only have a lowered number of capillaries, you only have a lower density. Another exercise. In this image, I count 1, 2, 3, 4, 5, 6 capillaries. Does it belong to rule number 1? No, because my density is only 6. Does it belong to rule number 2? Please reply in the room.
Yes, 2. It's a giant.
Yes.
It's more than 65.
Wonderful. Perfectly, Saira. So in fact, this is a scleroderma pattern we see with a fast track algorithm. Yes. And just something more, but which you don't need to know after today, it's an active pattern because you have the combination of a lowered number of capillaries, less than 7, we only had 6, and giants and hemorrhages. This is an active scleroderma pattern. Okay, next exercise, please. Somebody in the room, help me. First count the number of capillaries and then tell me if it's rule number 1, 2, or 3.
So 1, 2, 3, 4, 5. But these are concave shape, so this is abnormal.
Just count.
Yes, yes, but first I would like you to count the number of capillaries, and then we will evaluate together the dimension, and then we will evaluate together normal or abnormal shape. So yes, let us restart. 1, 2, 3, 4, 5. Yes, continue.
Yeah. 5, 6,
8,
6,
7, 8.
And 7.
no,
8.
6.
8.
8. So which rule is it? Is it rule number 1, 2, or 3?
1.
Vanessa, again, that the thing which is confusing us
can you please,
is which one to not to count if it is like low on the lower side. So what is the cutoff?
You don't count these.
Okay, fine. But
you don't count these.
Okay. So then starting from
can you show us how you are counting?
A tortuous and the very dilated one.
Yes.
1.
1.
1. Then next 2, 3, 4, 4, and then this
5,
cross 4, 6, 7, 8. Okay, then it's 8.
Yes.
It's normal. Then count is normal.
Vanessa, one thing I don't understand
Yes,
is that,
Saira?
is the third capillary, you know, you counted 1, then 2, yeah, 3, 4. Is this, there's a drop of capillary in between, isn't there? Between
Yes,
the both.
but this is why we teach you the fast track algorithm, Saira. And this is why we told you it's very important to use a 200 magnification, because deletion zones and dropout is a very nice descriptions, but this is with the wide field technique of last century of Marek, who used a dermatoscope. So if you see this image, and like you, Saira, in the beginning, and that's why I put it here, in the beginning I was worried, is this dropout, is this scleroderma pattern? No, no, no. This is a 200 magnification and we use the fast track, and with the fast track algorithm we see, like it was said, it's more than 8 capillaries and we don't have giants, so it's a non-specific abnormality. And this is important. I'm so happy you asked me this question, Saira, because when I started with a 200 magnification in 206, I also said, oh, but is this a dropout? And oh, is this a dropout? And dropout should be scleroderma pattern. But we must know, and this is why Professor Coutelot stressed so much in the beginning in his first lecture, we must use all the same magnification and the same terminology, because otherwise we start calling images which can occur in you or me scleroderma pattern, and we don't want to do that.
How about the shape of these last, like 5th, 6th? Are
Thank
they
you.
concave?
Thank you so much. Yeah. This is indeed, as you said, this is not a normal shape because the tip is not convex, it's concave.
Exactly.
This is not a normal shape,
Exactly.
but it's a non-specific abnormality. As you can see here, these are non-specific abnormalities of shapes, and this can occur in all of us. Next time we will come and we will bring the 200 magnification and we will execute on us. In fact, when I first went in 2007 to the department of Professor Coutelot, they executed on my nail folds capillaroscopy, and the assistant phoned Professor Coutelot because I had some dilations, but it can occur in a healthy control population. As I said in last lecture, you can have one or the other non-specific change. That doesn't mean you have a scleroderma pattern. And this is why we thought we had to make this fast track algorithm. And in fact, we have validated this on novices in an Eustar course, and afterwards we validated it, first at an Euler course, and afterwards we validated it on novices, people like you, which we train 1 hour. I'll do that next time when we come to you. And we had excellent reliability. Shall I do another image, or is there more questions on this image?
You can move on.
No, I think
Thank
we
you.
can move on, yes.
So in fact, this is non-specific abnormalities. Okay, now I let you do another image. Please, somebody in the room, because I can't see you, so sorry if I don't smile, but I only see my own screen. Yes, here you have the linear millimeter. Please count the number of capillaries and tell me if it's rule 1, 2, or 3.
1, 2, 3, 4, 5, 6. I see 6 capillaries.
Okay, I agree. So I do 1, 2, 3, 4, 5, 6. I fully agree with you. And normally the machine does it for us, but I can't do that. But I have here measured the apical diameter. It's 15 micrometer. Okay, so a comment further on this image. First do the fast track, and then we will comment further.
So,
Tell me, is this a scleroderma pattern or not, please?
So the number is less than?
Less than 7.
7. That is one abnormality. However, the shape is not that bad. Maybe the capillary
dimension.
number 5.
Well,
This
I
is
think we should
tortuous,
first
but this
use the
can
fast
be a
track
normal
algorithm,
variant.
then classify a scleroderma pattern or not, and then we will use this table to explain a little bit to each other. But what I want you to be able to do after these 15 minutes is to classify an image as scleroderma pattern or not. So tell me, is it rule 1, rule 2, or rule 3?
So I think this is category number 2 because the number is less than normal. And I think there is one giant.
Category 2 is 2 options. You have the category 2 is this. Then you should have a giant or the combination of less than 3 and all abnormal shapes. This is not a factor.
Then I'll move to category 3.
Me too. So fully correct. It's category 3. Why? It's not category 1 because your density is less than 7. It's not category 2 because you don't have giants and you don't have a density of 3 or less. So it's category 3, which says we can safely classify it as a non-scleroderma pattern. I'm very mean, this is why I put this here. This is a non-scleroderma pattern. In fact, what you see here is a lower density, a normal dimension, and some abnormal shapes. But this can occur in Saira, in Bilal, in Professor Coutulo, and in myself.
Right.
May I show another image?
Yes.
Please, someone in the room? The green lines are the 1 millimeter. Is my density 7 or more?
So should I count first? So 1, 2, 3, 4, 5, 6, 7, 8. Yeah, almost 9.
Yes,
8
9.
Yeah.
So it's
Is it rule number 1, 2, or 3? 1. I have measured here an apical diameter for you to see. It's 19, so nothing is above 50. So is it rule 1, 2, or 3?
1.
So it's 1. It's still
Yes.
It's no giant.
It's non-specific abnormalities.
Yeah.
Again, in the beginning, I used to mail these pictures to Professor Coutulo to ask him what it is. It's a non-specific abnormality.
Yeah.
I do see hemorrhages here, and that's worrisome. But hemorrhages, as we saw in my first lectures, hemorrhages can occur in connective tissue diseases, lupus, any other connective tissue disease, systemic sclerosis, undifferentiated connective tissue disease, even in 5% of healthcare controls. And Professor Coutulo showed you in his lecture one disease where you can expect these comb-like hemorrhages. Do you remember? No. In the anterior phospholipid syndrome, you can have these hemorrhages, these comb-like hemorrhages. But this image, you just need to be able to say it's not a scleroderma pattern. Why? Otherwise, when I come to you with Renault and this image, you will say, Vanessa, you have a scleroderma pattern. You must be screened for systemic sclerosis. No, Vanessa, you don't have a scleroderma pattern.
Yeah. Okay.
Shall we do another image?
Yes, we can move on.
Vanessa, so in somebody who has been exposed to extreme low temperatures, like a cold injury or frostbite kind of a thing, so can we have these kind of small micro hemorrhages in the normal subject when they are exposed to cold?
In normal subjects, in 5% of normal subjects, you can even have hemorrhages. Have there been specific studies about frostbite? I don't think so. Professor Coutulo, have there been specific studies on frostbite?
In short term, no. In long term, yes.
And what did you see in those long-term studies?
Long-term studies, there are studies in worker in the freezing industry where the long-term exposure to the cold with the hands may induce some changes due to the continuous vasoconstriction induced by the cold. This may be a damage because the vasoconstriction means also hypoxia for the tissues, and some of the microvessel may be damaged by this continuous per hour hypoxia for long term.
Thank you. And what did you see in these studies as changes?
No, not personally.
Okay. Thank you. Shall we do another exercise?
Yes. Yes.
Okay. Someone in the room? This is my 1 linear millimeter, the green lines. Somebody can count and tell me if this is rule 1, 2, or 3?
So
there are 2.
So there
just the density is 2. So
yes, just 2.
Correct.
Yeah. So and there are giants as well. So
no, there are abnormal shapes.
Abnormal
this
shape.
Is an abnormal shape.
But it is less
this
than
is an
3.
Abnormal shape.
But because the number is quite less, it's less than 3. Even then, I would say that
yes.
it is scleroderma pattern. No matter there is no giant.
I fully agree with you, and this is why I put it here. Some comments to you. Normal shape is hairpin shape, torches, or crossing once or twice. Yes. The tip must also be convex. So you are fully correct, these are abnormal shapes. These are not giants. Giants, per definition, must have a normal shape, so one of the 3 shapes we said, and an apical diameter of 50 or more. So these are not giants, these are 2 abnormal shapes, but you're fully correct. Because the density, the number in 1 linear millimeter is less than 3, and because they're abnormal shapes, we categorize this as a rule number 2, which says it's a scleroderma pattern. Of note, it's a late scleroderma pattern. Late scleroderma patterns have been associated, as we saw in the first lecture of Professor Coutelot, ulcers, mortality, interstitial lung disease, and more severe disease course. I do not know if we have time to go over the reliability, but I will just tell you quickly, and then I will show you the last slide of the reliability. This fast-track algorithm we have taught to the attendees of the Euler course in Genoa and to the Eustar course in the Netherlands. And we had lots of novices who didn't have any experience at all. After teaching it to them, we gave them an exam to classify a scleroderma pattern or not scleroderma pattern. And we tested the reliability. The reliability of the pink ones are the attendees, reliability versus themselves and the golden standard, or the reliabilities of the attendees versus the golden standard. We had lots of novices. In the Euler course, we had 68 novices, and in the Eustar course, 47 novices. And the results were that we had a very high inter-rate reliability, 0.98 of people who never had a technique. And in the external validation, again, 0.93 of reliability. So we do believe this is a very trainable algorithm, this fast-track algorithm. We trained it in 1 hour, and we had an excellent reliability between the novices and the golden standard, of course, also with the other attendees. I do not know how much time there is left. If you want other exercises, I brought others, but I don't know what the afternoon planning is.
I think Professor Coutelot and Vanessa, it was really great learning session. So we thoroughly enjoyed it. So, and I believe, yes, we can see that we were completely novice from that point of view. But yes, after the session, your objectives, which you both laid out at the outset, they have been fulfilled. And it is very fulfilling, it's really very rewarding. And we hope that next time we can both of you, we can have you in Lahore. You will really love our hospitality. We have a beautiful city, and hopefully things will be better next time in terms of COVID, in terms of political turmoil and economy, and we'll be able to meet frequently. Thank you.
Thank you. Thank you so much.
It was our extreme honor. Thank you so much for the invitation, and we really do hope to come, and we will bring our capillaroscopes to you. Thank you so much again.
Thank you.
Soko, just few words.
Thank
few
you.
words, if you want. I remember when Sarah approached me in Euler and said we would like to organize. This was the beginning of the story. Then, unfortunately, we know what happened, and we are very sorry what happened to your country. And this was a real disaster, even more than COVID, probably. And now we add, in any case, because the science, clinical science, the wish to learn has no limit. We use the modern system, and we had a wonderful meeting. Thank you very much.
Thank you.
And so,
Thank you so much.
we hope to see you again.
I'll request all the participants to please
Thank you. Physically.
Click on the feedback link and give the feedback in order to receive your certificates. And I want to thank Professor Vanessa and Professor Coutelot.
Ciao, ciao.
Thank you so much. Hope to see you next time. Bye-bye.
Bye-bye.
See you soon.
Thank you.
Bye-bye.
Thank you. Bye-bye.